So, welcome again here to the Charles Institute of Dermatology and to Dublin.
Thank you.
Let's talk about rosacea. Do you see many patients with rosacea in your practice, in your private clinic in Belgium?
Yes, rosacea is fairly common in Belgium, and I'm studying this dermatosis for many years, so it is become my specialty. As you erythematotelangiectatic rosacea or subtype 1 rosacea is mainly seen in that portion of the population that are fair-skinned. But concerning the papulopustular rosacea or subtype 2 rosacea, I see it also fairly frequently on slightly darker skin as on patients from the Maghreb.
That's interesting. So you, like me, make a distinction between erythematotelangiectatic rosacea
Yes.
and the papulopustular variant. Do you think for the clinician, for the dermatologist in clinical practice, that using the subtype classification of rosacea is helpful or important?
Yes, the subtype classification is indeed useful as it allows us to distinguish between the various clinical conditions that a patient with rosacea may have. In addition, each subtype of rosacea possibly has complementary but different pathogenic mechanisms, and in consequence their treatment can be quite different.
I agree with you. And in fact, the treatment, as we know, of the different subtypes is quite different. And it may be that there are different pathogenic mechanisms at work in the different subtypes, making them different but somehow related conditions.
Yes.
For example, the patients with erythematotelangiectatic rosacea who have a red face, who flush easily with changes in temperature, and who sometimes have broken telangiectatic vessels, in my opinion, the clinical picture they present is very similar to that we see in fair-skinned people who are exposed to weathering. And by weathering, I don't mean just sunlight. I mean wind, cold, and every other factor in the elements. And then there is the subtype 2 papulopustular rosacea, and as you know, those patients clinically look quite different.
Yes.
They have inflammatory lesions, and by that we mean papules, pustules, and they're on the central face area, the middle of the forehead, the nose, adjacent cheeks, and the chin. In those patients, there seems to be a different pathogenesis in my view. There may be, in some of those patients, a burden of excessive numbers of Demodex mites. In your opinion, are Demodex mites playing an important role in the pathogenesis of papulopustular rosacea?
Yes, in my opinion, the role of Demodex is central to the pathogenesis of the papulopustular rosacea. We have known for many years that the numbers of these mites present in the facial skin of rosacea patients are greatly increased compared to those people without rosacea. This overpopulation of Demodex, through the damage of the follicles in which they live, could trigger the inflammatory changes in the skin and result in the condition we call the papillopustular rosacea.
See, now clearly it is normal to find mites in the skin of patients who have normal appearing skin. The critical factor seems to be the absolute number of mites that are present. Both you and I have used the skin surface biopsy technique for retrieving mites from the skin, and you have advanced that technique to produce the standardized skin surface biopsy technique. Can you explain to me the difference and what your development has brought to the study of rosacea?
Okay, as you know, the skin surface biopsy existed for collecting the superficial part of the skin and observing living mites. But to detect mites is not very useful because, as you said, we know that they are present in facial skin of all adults. In other words, the simple presence of the mites has no clinical significance. Their pathogenic role is probably related to their excessive proliferation. So we decide to standardize the surface analyzed by the skin surface biopsy to 1 square centimeter and called this technique the standardized skin surface biopsy.
So if I understand, this allows you then to study the population of Demodex mites in a designated area of the skin. Is this correct?
Yes, this allows us to obtain the density of the mites on 1 square centimeter in a simple reproducible fashion. And in this way, the mite density of a patient can be compared to what is expected in an adult with normal skin. For example, this technique allowed us to demonstrate that the higher Demodex density in the skin of patients with rosacea is far greater than individuals with normal skin. Let me show how we do it in practice on this video taken in my practice in Belgium. This video explains how to perform a standardized skin surface biopsy in practice and so to detect high Demodex density during the consultation. Firstly, we clean the patient's skin with heater. So the sebum layer is then removed and the opistosomes of the mites appear more clearly. With another paper handkerchief, we clean 2 slides with heater. We take 2 slides because we perform 2 biopsies successively at the same place. We put down each of the slides on a sheet of standard square paper and with a waterproof pen we draw a standard surface area of 1 square centimeter on the lamina, tracing by transparency on the paper. The analyzed surface is then standardized for 1 square centimeter and is called the standardized skin surface biopsy. Then we get cyanoacrylic adhesive superglue. We turn up the lamina and on the other side we place 1 or 2 drops of cyanoacrylic adhesive on the slide and we put it on the skin surface. During all the procedure, the patient has to keep the eyes closed to avoid irritation by evaporation of the glue. We wait for 2-3 minutes. After it has been allowed to dry, we remove it gently. If a small piece of the biopsy stays on the skin, it can easily be taken out with an Hudson gripper. Then, on the same place, we put a second identical lamina to get the mites of the deeper layer. It is very useful to prevent a false negative result with only 1 biopsy, occurring in 5% of the cases. So after 2-3 minutes again, we remove the second one gently. To alleviate the small discomfort of the biopsy, we apply a soothing cream on the place of the biopsy. After removal from the skin, the sample is clarified with 2-3 drops of immersion oil and then covered with a cover slip. So we can go to the microscope to obtain the Demodex density during the consultation. Here on the left we can count 8 Demodex in the follicle, and on the right side we see 4 follicles with 3 to 5 mites per follicle. By counting the Demodex on the square centimeter, we obtain the Demodex density.
We still have a lot to learn about Demodex, its interaction in normal human skin, and its possible role in rosacea. I think it's incredible to think that the vast majority of doctors have no idea about this 8-legged creature that lives in the oil glands of our facial skin. Down here we have a section that are working on Demodex mites, and in this section we're doing several different kinds of experiments. Noreen, I'd like you to meet Dr Fabienne Fortan, who's come in from Brussels. So that means, in essence, that you get an overall view of the structure of the mites, much more detailed than you previously would have done with the compound microscope. Is that correct?
That's true. When the cover slips press down, the mites tend to come out of their follicular plugs, and yes, they can get damaged during the process also. We've also adapted the 1 centimetre squared counting area to make it into smaller grids with a geographic map, so we know where the mites are in each grid, and we take note of adult mites and all the life stages. Yeah. And then we count the amount of mites in each one of these grids to yes, total the number. And
the advantage of that is that we can study mites in a particular part of the slide. We can also look at mite mobility. For example, if the mites migrate from one part of the slide to the other, we can identify that. And then finally, if mites change, for example, sometimes we see ova or eggs of mites, and it's possible that these may subsequently develop into larvae, and if we have identified where those eggs are, and then subsequently we can see a more developed stage of the mite, then this gives us a knowledge of the life cycle of this organism that we really didn't have before. After we identify the mites and the live mites, what is the next procedure?
Because we really don't know what these mites do in the biology of normal skin as well as disease state skin, we're now isolating the mites from the skin surface biopsies, and I do this by gently teasing the mites from the follicular plugs using a fine forceps.
How fragile are these organisms?
They can be very fragile.
Yeah.
It's taken a long time to develop a very steady hand to gently nudge each mite singly from a follicular plug.
And then when you extract these living organisms, what do you do next with those?
I moved the microscope and the samples into a cell culture sterile environment, and then I gently teased the mites out with the forceps and placed them on top of into medium with skin cells.
Yes, and which kind of cells do you use?
At the moment we're looking at the effect of these mites on a keratinocyte cell line and a sebocyte cell line.
So we're trying to reproduce in the laboratory environment as close as we can to what happens in the actual skin in patients, not only patients with rosacea, but in fact in normal individuals. And what has your research been showing to date?
To date, it seems to show how mites in low numbers evade detection by the immune response. However, as the mite numbers increase, it seems they're able to induce an inflammatory response. But this is seen a lot more with mites that have been taken from the skin of rosacea patients. So there seems to be a difference between mites in normal skin versus mites in the skin of patients with rosacea.
And one other thing, how long can we keep these mites alive in the laboratory?
After optimizing our transport system and specialized humidity chambers, we can keep these mites alive for anything up to a week without removing from the skin surface biopsy.
So that's fascinating. You can maintain them alive for up to a week. And have you seen any development of the different stages of Demodex mites under the microscope in those circumstances? In other words, larval stages changing?
Well, we've removed some of the ova and put them into our cell culture medium, and we've seen the ova change into the larval stage.
That's absolutely fascinating. Thank you very much, Dr. Lacey. We have a lot to learn about this organism, and perhaps it's also doing some good in our skin. We mustn't overlook that possibility. And now, Fabienne, I'd like to thank you very much for coming to Dublin, for coming to UCD and visiting our Institute of Dermatology and sharing your wonderful experience of many years studying Demodex and your adaptation of scientific techniques.